Thank you for this opportunity. I am John Schenecker. I am a pediatric orthopedic surgeon from Vanderbilt University, and my clinical focus and my laboratory focus, a big part of it is to figure out how to survive severe injuries. Today, I would like to talk with you about how our perspective is on the continuum of plasma dysfunction during severe injury and how we think that it is a cause of at least some, if not all, of the morbidity and mortality in severe injury. So if we're talking about severe injury, it's very helpful to think about the morbidity and mortality that happens and divide it in two different time periods. If we start with the early convalescence, what we're referring to are the problems that can happen from bleeding out or hemorrhage or thrombosis. If we consider then what happens in these patients in late convalescence, they're very susceptible to having problems such as failed repair of tissues, in this case of a broken bone, or degenerative problems from continuous inflammatory responses. Together, these problems can be considered post-injury syndrome, which is the majority of cause of pain and dysfunction in these patients after a long recovery from an injury. So if we put all of these major adverse outcomes on a scale, one of the most important things to understand is that typically these problems happen in the exact same patient, meaning that the patient who is at risk for hemorrhage and thrombosis is often the same patient who later on has failed tissue repair or tissue degeneration. And so we can consider these adverse outcomes in these two different time periods, but they are connected, and we think they're connected by the same pathophysiology. And our hypothesis is that this plasmin continuum is a major part of the pathophysiology that links all of these problems. So to explain our hypothesis briefly before we do a deep dive on this topic, let's consider what happens in early convalescence in hemorrhage. Any big injury is going to activate lots of thrombin. The thing that happens in severe injury is we have untimely activation of plasmin, which we'll get into detail later in this talk about why this happens. This is what leads to what's considered to be hypofibrinolysis, or exuberant plasmin activity in that early convalescent period, leading to this hemorrhage. And a big thing to think of in almost all aspects of biology is thrombin and plasmin being activated together is never good. We think that what then happens is that the neutrophil, as depicted here by this angry spider monkey with a knife, is one of the main things to counter this hyperfibrinolysis by creating a damaged matrosome, which used to be called the fibrin clot, out of fibrin and DNA to resist that plasmin activity, leading to a profound hypofibrinolysis early in convalescence. And this is fantastic because we need this if we have hyperfibrinolysis to counter that hyperfibrinolysis and to survive so we don't bleed out. However, we also postulate that this hypofibrinolysis has a lot of collateral damage and can lead to thrombosis throughout the body. In addition, we think that this damaged matrosome and other aspects of hypofibrinolysis that is caused in response to this hyperfibrinolysis leads to a deposition of a damaged matrosome that is very hard to clear and can continue to cause risk of thrombosis, but also can lead to problems with failed repair of tissues, such as this fracture, as well as degeneration of tissues, which can happen later on. So consider this in terms of what we think happens in severe injuries is there's a continuum of plasmin dysfunction. And again, it started off by this initial hyperfibrinolysis and is blocked and countered by this hypofibrinolysis and can lead to prolonged hypofibrinolysis later in convalescence. And we do think that one of the major aspects of this that happens is this activation or counter by the neutrophil, but we will also say that there are other mechanisms that this probably happens as well. But That being said, think of this initial hypofibrinolysis that may happen in the early convalescence as trauma is actually being good. Is that this probably is what makes it so that we don't bleed out and die, but has severe consequences that can really extend into our long-term problems that we have after a major trauma. So the biggest aspect about this is we have to learn how to diagnose and treat these problems. And so the goals for the rest of this talk is to get us all on the same page to know what we're even diagnosing. So we'll start off by defining what MODS is, then talk about the normal acute phase response, then the severe acute phase response, and then we'll go over ways now that we treat these problems. And then we'll also then talk at the end about strategies as to what we can do for the future. So starting off, let's talk about multiple organ dysfunction syndrome, or MODS. Basically, this is a denial of service. We often talk about this as big clots, as thrombosis of a DVT, a PE, a stroke, an MI, etc. These are the large vessel problems that happen, but it actually probably is more common that we have small vessel problems. And these small vessels can either be intravascular or, just as important, extravascular. And essentially, these can clog up organs and cause major problems. These also are, as we just discussed, probably much more common than the larger vessel problems. And this is what typically ends up leading to organ failure after severe injury, which we'll talk about a little bit more later. And from my perspective as an orthopedic surgeon, also understand that if this is happening all throughout the body, we postulate that this is why we have a lot of problems within injured and uninjured tissues, is that we think that these problems are causing small vessel and interstitial accumulation of this damaged matrosome throughout and can be collateral damage. So why does this happen? Well, one of the other biggest things that I'd like to get us kind of in definitions on the same page is that what we were taught in medical school is that the fibrin clot is the main player that makes it so we don't bleed out and what we need to consider. But what's new is that we're now learning that fibrin clot is often modified necessarily. It's scaled in order to be more resistant, in particular to plasmin. And therefore, in order to be inclusive about the matrices that are within that, we like to refer to this as the damaged matrosome. So it's not just referring to fibrin. And this is simply a matrix that's made rapidly in response to injury that seals the wound, traps bugs, and stops bleeding, but can also clog organs, leading to multiple organ dysfunction syndrome. So the key then is, how is all of this balanced? Well, if we start off with the orthopedic acute phase response to see what happens in a normal injury, when we have an injury, it creates 4 problems that we need to resolve. Because of this breach of compartments, we have bleeding, susceptibility to infection, tissue hypoxia, and tissue dysfunction. The acute phase response simply is an endocrine system that resolves these 4 problems of injury, and they do this by releasing elements that will travel to the effector organs or the surrounding tissue to activate this emergency endocrine system. In the liver, lung, and kidneys, the main effector organs of this response, they end up producing over 1,000 acute phase reactants over time with the intent of resolving these problems. The coagulation and inflammation system stops bleeding, stops infection, then leads to angiogenesis and maturation or differentiation of whatever tissue is trying to be healed. A really important part about this is all of these problems are resolved in order. First, we make sure that we stop bleeding and achieve hemostasis. Then we stop infection. Then we move on to tissue angiogenesis and then maturation. This allows us to group the acute phase response into 2 specific phases. We have a survival phase where we have temporary containment, and we have a reparative phase that leads to a permanent solution. So if we look at how we see this in terms of timing of what we see on the wards with people who have these injuries, if we look at the survival acute phase response, is that we first have to take care of bleeding, then we have to resolve infection. Well, simply put, the coagulation system and the survival inflammatory response are the key aspects to stop these problems. One thing to realize is that out of those 1,000 acute phase reactants is the majority of them are controlled by cells, meaning you need the proper cell-to-cell interaction or just cellular interaction to make it so that these effector responses actually are carried out in that tissue. So, for example, the coagulation system contributes platelets, which one of their main jobs is to activate thrombin and create primary and secondary hemostasis. Then you have your neutrophil, which we will talk about in a bit in terms of how it regulates. And then we have our angry macrophages, as we like to call them. So those platelets are essential for laying down fibrin, releasing some cytokines, and creating the initial fibrin of that damaged matrixome. They also release polyphosphates, which we can talk about at another time. We then move on to the neutrophil. The neutrophils are really important to understand in terms of how they contribute. They respond to DAMPs, or damage-associated molecular patterns, or PAMPs, pathogen-associated molecular patterns. And this is where it's really fun to refer to In a Nutshell, which is a great YouTube group that makes incredible science movies for anybody. And one of their main ways they describe the neutrophil is this, is it is a spider monkey that has been drinking lots of caffeine and carries around a knife. And the way the neutrophil fights is that he comes screaming up to the wound itself, like in a battle with somebody else, stabs himself in the gut, starts pulling out all of his gut, takes ribs, stick it into the gut, swings it around, whips you with it, then jumps on top of you and dies. And the amount that they go crazy is dependent on how many PAMPs and DAMPs are around. And that aspect is, the analogy is that the guts are the DNA nets, and then within that, those rib spikes are histones, which are incredibly inflammatory. So in this aspect about it, we have netosis that can happen in a wound, and this is where neutrophils are really cool, is that they can modify that damaged matrixome to achieve hemostasis. But what's awesome about that is to think of this, is that means that neutrophils are part of coagulation and they make it scalable, which I think is really important when we consider later a severe injury. So then we move on to resolving our infection, and that's where that DNA net and fibrin mesh can trap bugs. They have cytokines that can kill. Neutrophils can either phagocytose, or we just talked about, whip those bacteria with nets or jump on top of them and die, or even eat them. And then your big eaters, the macrophages, can come in and clear everything out. This is how that fibrin clot is as an antiseptic. We then move on to repair, and this is where we restore function, where we have to resolve hypoxia and tissue dysfunction. This is an active process that we call turning the corner, and it is where we turn our inflammatory cells from survival inflammatory to reparative inflammatory, and we see phenotypical changes that happen in patients that are indicative of this, such as no longer having pain or fever. And that's because the pain and fever typically are called by those survivor inflammatory cells. We then move on to remodel that matrix, lay new pipe for vascularity, and repair the tissue. And in essence, the way you want to think about this, what's been discovered about the fibrinolytic system, is you must dig yourself out of this damaged matrix. And plasmin is one of the main proteases that does this. So plasminogen is one of the 7th highest proteins circulating in your blood, and its receptor is basically any injured tissue. And so it will stick to that tissue, and it's primed and ready to go during survival APR. But one key take-home point is it shouldn't be activated until we get into repair. So plasmin should only be activated in repair. And again, the purpose of this is to dig us out and to heal all of that tissue. So when we talk about the acute phase response with the non-severe injury, most physicians don't even really think too much about this, because it's rare these patients have life-threatening hemorrhage, thrombosis, or failed tissue repair, or develop degeneration. When we switch over to the severe acute phase response, that's where everything is very different. The severe acute phase response, because we have a bigger amount of DAMPs, is already bigger. So remember that the survival APR is proportional to the injury DAMPs. And so from that standpoint, we're already at more risk of having collateral damage because we'll have more neutrophil activation, as well as some other aspects of it. This is what we typically see in a moderate injury, such as a long bone fracture, a big elective surgery with an EBL just under 300, or a minor infection. Now, if we switch over to a major infection, like a level 1 trauma, and a surgery that has a greater blood loss over 300, for example, or a major infection, is something happens that we don't completely understand why, but we think is at least in part from a bolus of TPA, is the fibrinolytic system gets activated early and it's inappropriate. And in this sense, we are digging out of our damage matrix way too early during survival. And this is the part we were talking about before. In your lifetime, you never want to have a considerable amount of thrombin and plasmin fighting against each other. It's never good. It's like the ultimate battle in Super Smash Brothers. And in this, that fibrinolytic system gets rid of that early containment, and that seems to be what leads to the early bleeding or vascular leak that happens after a severe injury or in a big elective surgery. This is the second peak in death following trauma. It then also liberates a ton of DAMPs. Those DAMPs then activate the neutrophils, and that consumption of the coagulation system starts to happen where we have a coagulopathy that's consumptive. And this leads to extreme activation of platelets and neutrophils, sometimes even aggregates, leading to a scalable coagulation that has absolute containment where a mixture of fibrin, DNA, and polyphosphates create a mechanically more stable damage matrixome that is resistant to plasmin. And that ends up leading to wonderful things. You survived. But it also is what leads to the immunocoagulopathy, and if activated everywhere, leads to thrombosis and MODS. So this is metastatic, and this can cause a huge problem and ends up being the third peak in death following trauma. So in this sense, the severe acute phase response, it's pretty easy to understand how these neutrophil activation can lead to thrombosis and MODS, but it's also what makes it so you survive the second peak in death. And so this is where we think it's really important to understand how, especially in early convalescence, the same patient is just at different times here in terms of what we're seeing. Then when we take a look at what happens repair, we and others have shown that persistent damage matrixome can lead to tissues not healing very well. And that plasmin also is an important active off, which is now consumed because it was used in survival acute phase response. And now you also have an immovable matrix, which is almost impossible to get rid of. And we think this is a big reason is what leads to the failure of tissue repair, fibrosis, degenerative disease, and pain. So think of the severe injury acute phase response in terms of how all of this links these pathologies and potentially what we could do about it. So when we get into treatments now, most of what we do is reactionary, is that we transfuse after the hyperfibrinolysis has gone off. As we're consuming coagulation, we either give it back or we try to use anticoagulants to calm everything down. Right now, the main thing that we try to use to calm down the neutrophil response and other inflammatory responses are steroids. And then we also are trying to come up with ways of treating these immunocoagulopathies. And how we treat these platelet neutrophil aggregates, for example, is why we learned a ton from COVID. And that's where there was actually a upside to COVID, if you could ever say there was. And that is just there are lots of new drugs that target neutrophils and nets that are coming out. But the main way we take care of it now and works very well is to prevent it if you can. And so that is where we use antifibrinolytics. And just remember, as we talked about, is that the Velcro that plasminogen binds to, they're called N-terminal lysines. There are many receptors. You don't want it to be activated during survival. So instead, what we use are things like TXA or Amicar, which are just soluble lysines or mimics of these receptors. And those block the plasminogen from binding to that injured tissue. It then causes that fibrinolytic response to not occur in that pathologic way. What that leads to is your containment is preserved, which makes it so you won't have that bleeding and vascular leak, which means that you don't have that big release of DAMPs from the fibrinolytic aspect of that initial damaged matrixome, which should make it so that we have far less SIRS and consumptive coagulopathies and less of a immunocoagulopathy. And this is a really important point. This is where blocking fibrinolysis actually leads to less thrombosis and multi-organ dysfunction syndrome, which really is counterintuitive as to how fibrinolysis is taught. And so in this way, it's also great to think about this as TXA actually is an anti-inflammatory, because we think one of the main ways is it prevents the scalable aspect of coagulation with that neutrophil activation. But something that's really important to talk about is the timing and duration is not really worked out, especially in severe injury with these. There's so much to learn is that we're worried that if we give TXA after we've already had hyperfibrinolysis go off and the patient's already in hypofibrinolysis, is that we can make everything way worse by adding more antifibrinolytic. So if we look at our severe injury and we go to strategies, just realize that one of the biggest things that I think everybody needs to look into is MODS is a really big deal. I think a much bigger deal actually than hemorrhage, and I think can occur without hemorrhage. And so along those lines, I think everybody needs to get really good at diagnosing and measuring MODS to figure out how we can treat these patients better. And then understand that the severe acute phase response, it's really important that we were to pick up on this before the MODS happen so that we could actually treat it appropriately, so that we can treat MODS if we diagnose it. If we see a severe acute phase response, prevent it and prevent the severe acute phase response from ever happening. So I hope this makes much more sense, and that the idea that treatment depends on where you are and what's needed are really good ways of measuring all of this, and really good pharmacologics to block or get us out of the pathologic phase of plasmin dysfunction that we're in to treat these patients. I want to thank all of my partners that I've worked on with this. I probably have left some people off of here, and I apologize about that. I also absolutely want to thank everybody who has funded this research. I think we're making a really big difference. Thank you.